hyperhemolysis, as we all have come across, it's a dreadful situation, very sort of a demanding clinical scenario, and we have all come across it at some stage here and there. But usually it's associated with sickle cell disease, and very, very rarely we come across it in a different situation. That's why we chose to present this case, because this was a situation where somebody who developed hyperhemolysis despite not having any sickle cell disease. So this gentleman, next slide, please. Next slide, please. Yep. So thank you. So yeah, this is basically a 67-year-old gentleman who was routinely referred to one of my colleagues at East Surrey Hospital. He had macrocytic. He was found to have macrocytic anemia and hepatosplenomegaly. All the workup in the primary care was all negative, so he was referred to us for further investigation. He was relatively asymptomatic, just a little bit fatigued, but nothing else. And his anemia was dating back for a few months, actually. He did have a past history of hypertension. He's had slightly different lifestyle. He was a smoker, 10 a day maybe, with a regular alcohol intake as well. So obviously the mind went down to the gastric causes first, like people with liver disorders. But my colleague who looked at him at that time, he did say that his anemia is a bit disproportionate to the like amount of alcohol he takes. So his liver functions were essentially normal, and examination wise there were no stigmata of peripheral liver disease either. So before coming to us, he had a CT scan which showed mild hepatosplenomegaly, spleen of 14 centimeter and liver of 16 or 17 centimeter, but no lymph nodes. He also had been to the gastroenterology team. He had an OGD and colonoscopy. We only found few benign polyps, and there was no source of bleeding from anywhere as such. Next, please. Next slide. Thank you. So yes, we did quite a bit of a workup. I have summarized them all in one slide, but obviously they were done in a staged manner. His hemoglobin was 67. MCV was strikingly high at 130. White cell platelets normal. Ferritin was raised. B12 was raised. Folate borderline. And as I mentioned before, liver functions, renal functions, all normal. His LDH was also normal, and DAT was negative. His antibody screen was also negative. Because of such a striking ferritin level, he had a HFE gene analysis as well, which showed heterozygosity for H63D mutation, virtually ruling out hemochromatosis. So yes, macrocytic anemia, normal hematinics. Next stage of investigation, he had a bone marrow biopsy, which is on the next slide, please. So it was performed 3-4 weeks after his clinic appointment. Thank you. It confirmed this erythropoiesis. Cytogenetics were normal. The bone marrow was a bit hypercellular with patchy grade 2 to 4 fibrosis. They did find some non-specific clonal lymphoid aggregates, and then there was a borderline increase in mast cells. He subsequently had a mast cell tryptase which was also normal. So it was just thought to be a reactive phenomena, and we left him alone. So on the basis of these bone marrow findings, we give him the diagnosis of low risk myelodysplastic syndrome, and then he was started treatment with erythropoietin. Next one, please. Next slide. 32,000 units subcut once weekly. It did help slightly, but he was still requiring transfusions, maybe once every fortnight or so. We were keeping the hemoglobin above, trying to keep the hemoglobin above 70. So whenever his hemoglobin went down below 70 or he developed any symptoms, we topped him up. Because he's still requiring transfusions, we thought, okay, let's increase the dose of EPO. So we dose double the dose. So rather than 30,000, we started giving him 60,000 unit once weekly. But to some degree, he still remained transfusion dependent, but maybe looking back, his frequency didn't decrease, but he was still requiring it quite frequently, like once a month at least. On routine appointments, he was also found to have a murmur, which the cardiologist thought is more than likely because of his anemia. But he did have an echocardiogram at that stage, which did not show any abnormality as expected. Next slide, please. Now, during all these transfusions, as you mentioned before, his initial antibody screen were all negative, but in July, August time, he did develop an anti-K antibody, and since then he was given Cal negative blood. On one of these routine appointments, he contacted our specialist nurses that he was developing some symptoms. So blood was checked. His hemoglobin was only 47. That was in November 2019, a couple of months after developing his anti-K antibody. His hemoglobin was only 47. So obviously it was a bit too low for him to be transfused in a day unit because he required probably more blood. So we admitted and we topped him up. But rather than going up, his hemoglobin actually went down to 36. The plan at that time was give him 3 or 4 units of blood and discharge him. But because his hemoglobin went down so quickly, we thought, okay, let's do a further workup. On this occasion, his LDH was raised. His genetics were actually normal, completely normal. LDH was raised. But on this occasion, his DA3 was positive with IgG 3+. And he has like a slight positive relation with the C3D as well, which started thinking about is it hyperhaemolysis? At that time, we got in touch with our regional center as well. The other issue was whenever we transfused him, his hemoglobin kept dropping down again. Yep. Next slide, please. So throughout his admission, he kept requiring transfusion. So yes, we got involved, secondary care, and our regional NHSBT center involved, and we had an ongoing discussion with the regional transfusion center, with the transfusion consultant. They were under the impression that this sounds, although it is rare outside sickle, but this very much sounds like it should be managed like a hyperhemolysis phenomena. We gave him some, they asked us to withhold transfusions as much as we can. We gave him some methylprednisolone and intravenous immunoglobulins, which did work. And his hemoglobin went up to 69 or something, which was very close to his baseline. We did not transfuse any further. We continued with oral steroids. At this stage, he was good enough to be discharged. Sorry. Well, yes, he was followed up for a little while in our outpatient clinic. Afterwards, he was planning to relocate to east of England anyway, so went up there. And the most recent update we got from them is he's doing all right. He's very rarely requiring any transfusions, but he's only maintained on EPO and doing okay so far. Next slide, please. So I'm not sure I need to mention all this, but we all know that hyper is a rare, potentially fatal delayed transfusion reaction that primarily develops in sickle cell disease. The hallmark is a significant drop in hemoglobin, and which is lower than the pre-transfusion level. And delayed transfusion reaction usually occurs within 2 weeks of transfusion with evidence of severe hemolysis. Is associated with radiculocytopenia, which did not happen in our patient. But considering the amount of his anemia, one would have expected that his radiculocytes count would be higher than normal, but his was within normal limits. Transfusion with red cells usually exacerbates hemolysis, which was happening in our case, till we given immunoglobulins and steroids. And the typical phenomena which happens in hyperhemolysis is not only the transfused red cells are destroyed, the patient's own red cells are destroyed as well. And then, as management-wise, we all know that we give them steroids, IV intravenous immunoglobulins, and avoid transfusion as much as possible. So, looking back at this case, although we had ongoing discussions with our tertiary cancer transfusion colleagues, we looked back. We looked at all the cross matches and all the antibody screening. Since we discovered this anti-K antibody, he always received Cal negative blood. So I think the consensus was that this is all happening because of anti-LUA antibody. Anti-LUA antibody, we know about that one. That is rarely clinically significant and does not cause very many problems. But there was no other explanation in this case. Thank you.